Welcome everyone to today's webinar brought to you by Aspire Respiratory Products. This webinar is entitled Advancing Care for Individuals with Airway Protection Dysfunction, Translating Interdisciplinary Research to Clinical Solutions for Medically Complex Patient Populations. And we have Dr. Justine Dallal-York, who will be presenting for us today. Just a quick note before we begin, we ask everyone to kindly save their questions until the end of the presentation. We'll do our best to get to as many as possible, and if your question is not answered, you can always reach out to us afterwards. So a little bit about Dr. Dallal-York. She is a postdoctoral research fellow in the Laboratory for the Study of Upper Airway Dysfunction at Teachers College, Columbia University. She completed her PhD in rehabilitation science with a concentration in neuromuscular plasticity at the University of Florida, and her master's degree in biobehavioral science, speech-language pathology at Teachers College, Columbia University. Building on over a decade of clinical experience in otolaryngology and acute care settings, her research examines how multiple organ systems across the aerodigestive axis impact airway protection in medically complex populations and implications for advancing treatment. So from our conversations, I know that she is very passionate about bridging the gap between research and clinical practice. Thank you so much for being here with us, and we're excited to hear you present. So I'll hand the stage over to you.
All right. Thank you so much, Jenny, for that warm introduction and for having me here today. So, like it was mentioned, I'm Justine Dallal-York, and I'm excited to be here today to share some practical tools to promote the clinical uptake and translation of interdisciplinary research, and to discuss some recent research in airway protection dysfunction in medically complex patient populations. Here are my disclosures. So starting with a brief overview, first, I will take the time to provide a background and discuss the purpose of this talk. And I'll actually kickstart the talk by discussing some practical ways to narrow the bench to bedside gap. Then I will highlight some key research findings from 3 phases of research on airway protection and defense after cardiothoracic surgery, specifically after cardiac surgery and lung transplantation. And finally, I will conclude with a summary of central messages and evidence-guided recommendations. So, as many of you who work clinically here can likely attest, patients with the most substantial forms of airway protection deficits often experience both concomitant dysphagia and dystusia or hypotusia, defined as downregulated cough. And hypotusia typically manifests as too little or insufficient coughing, and the pathophysiology of hypotusia in individuals with dysphagia is primarily associated with cough hyposensitivity or reduced cough effectiveness. We know that this is especially true in medically complex patient populations, where both the presence of cough impairments and swallowing impairments create somewhat of the perfect storm to result in uncompensated aspiration or silent aspiration in critically ill and deconditioned patients, which we know in turn can impact long-term health outcomes and survival. Here's a figure from a practical review that was created in collaboration with my postdoctoral research mentor, Dr. Michelle Trochet, where we review how hypotasia may occur due to underlying afferent and efferent deficits in the neural control of cough, as well as how changes to the composite anatomy or structural changes may limit cough airflows or the coordination of laryngeal behaviors. And importantly, we provide a pragmatic, clinically relevant resource which overviews the literature related to swallow and cough biobehavioral interventions, including expiratory muscle strength training and other exercise-based rehabilitative approaches or compensations. And over here on the right side of the screen, there's a QR code, so you are all able to check out this free open access article. We hope you find it useful and helpful. However, we know that even with practical resources like this, even though we're trying to put them out, the research and literature is always evolving, it's always changing, and as clinicians, we always have to keep up with it. A rather large gap in an area that I feel passionately about is increasing the bidirectional communication between researchers and clinicians, and empowering clinicians to sort of digest and apply the latest available evidence in a meaningful and efficacious way in clinic. So to translate the data into clinical solutions. So the purpose of this talk is first to review an accessible resource to navigate airway protection research and to provide a review of key research findings in acute care populations, but to do so with a practical clinical lens. I will do this by discussing an interdisciplinary quality improvement project that I collaborated on with my doctoral research mentor, Dr. Emily Plowman at the University of Florida. And at the University of Florida Health Center, we worked on a quality improvement project, which was launched after clinical observations that there was increased bouts of aspiration in the cardiac and thoracic ICUs. And this involved a series of 3 phases of investigations. Before I dive into that, let's return to the question of how do we narrow the bench to bedside gap? So this was a big question we asked during the COVID-19 pandemic, where new research was constantly being produced, and there was a really high need to turn it over and apply it clinically every day in acute care practice. As many of you could probably relate, the COVID-19 pandemic really brought this issue to light. We were observing so many forms of ARDS and end-stage lung disease due to COVID. And while we were all in lockdown, a collaboration of labs across Canada and the US worked to lead through this problem. So, for example, in the top left, as you can see, in an equator network mapping review, actually over 542 guidelines from the equator network to look for checklists and guidance on subjects relevant to transparency and rigor in dysphagia research, not only to inform dysphagia researchers, but also to inform research consumers of necessary items to critically appraise the literature. And at the time, we felt that this was a really extremely relevant and time-sensitive and clinically salient skill. This also led to a cascade of the additional studies that you see below, which I'll also discuss further. So when we cut it down to brass tacks, our equator network mapping review really revealed the following knowledge gap: that there's a lack of guidelines specific to reporting and evaluating key methods in dysphagia research with both rigor and transparency. With this in mind, and it should be appreciated that this progression didn't necessarily happen linearly. It happened in tandem or synergistically with one another. We aim to introduce a critical appraisal tool intended to support researchers in airway protection and defense, research consumers, and clinicians. And what was the ultimate result of these efforts? Well, we designed the Frontiers framework, which stands for the Framework for Rigor and Transparency in Research on Swallowing. And it's really was introduced to guidance at various phases of research, reviews, or by clinicians, implementation, in collaboration with an amazing software. We designed a free open access website that covers 8 domains, and you could see those here. It includes universally applicable questions to all sorts of airway protection research, questions about participant characteristics, screening, or other instrumental assistance that are more brief testing or using high manometry, treatments of dysphagia, and patient barcode over here to take you directly to the website. And here is a video demonstration, which I will play, which you can see how these 8 domains sort of function. So you could see when you get to the website, you go to the setup assistant, and you're going to be navigated through a series of questions about any given article that you are researching. Here I select all 3 forms of assessment. I also, for fun, select a few different types of instrumentation tools that are potentially used just to show you what this output could look like. And it'll ask you, does this investigate a swallow treatment? Yes or no? Are patient report outcome measures used? And once you do this configuration, it brings you to this nice panel of questions under each domain. And this provides somewhat of a checklist to help you to triage the quality of the literature that you're reading, the evidence, and also can help you appraise the literature yourself to say, it seems like it may be missing this component. components. This article that I would love to, really work on to clinical practice, and this one maybe not so much. You're able to increase uptake of the literature and know which ones are maybe the most evidence-based to apply. I end here with the fees because the next studies we're going to be looking at involve flexible endoscopic evaluation of swallowing. And perhaps you could go ahead and, appraise the articles that we discuss. Okay, so with that, let's dive into the clinical portion. So as I mentioned earlier, the clinical practical portion of this talk all stems from a quality assurance initiative in the cardiothoracic ICU, where physicians had approached Dr. Emily Plowman and said, we're really noticing increased bouts of aspiration in our cardiac and thoracic ICUs. Would you like to get involved, and how could we help? Of course, we were very interested. And so what we did to begin to tackle this is we looked through the literature and we found a big knowledge gap that was essentially that no formal practice guidelines, as you can see, kind of, translates nicely to what we were discussing earlier, really existed, or validated screening tools existed specifically for the cardiothoracic surgical patients. So in light of this landscape and this current state of affairs, our central aim in the first phase of the QA initiative was to examine dysphagia assessment practice patterns and the current swallowing screening tools that were being used. Essentially, we wanted to know how dysphagia was being managed in the absence of these resources, and what was that outcome? How was it functioning? And although there was 2 studies that were a part of this phase, actually upwards of 3, I will just go ahead and highlight one for the sake of time, particularly as it pertains to the swallow screening tool that was used in the cardiac ICU at the hospital we were in at that time. Ultimately, we found that this particular screen was a barrier to care. So this was a single-site prospective cohort study that enrolled participants from a convenience sample. Participants underwent a 3-ounce water swallow test, a simple bedside water drinking test, where participants were asked to drink 90 ml of water without stopping. And this commonly used dysphagia screener was the current standard of care in the cardiothoracic ICUs. And typically, the 3-ounce water swallow test, as we know, has an excellent sensitivity at 97% for heterogeneous cohorts of hospitalized adults. So this means that out of 100 inpatients with dysphagia-related aspiration, 97 out of 100 would be correctly identified with the 3-ounce water swallow test for further dysphagia evaluation or SLP services. But we found, in contrast, were pretty striking results, as we thought it was a very sensitive test. Instead, we found that the 3-ounce water swallow test only had 63% sensitivity in detecting aspiration in cardiac surgical patients, missing over a third of aspirators. So in conclusion, in phase 1, gestaltly across all the studies, we identified that there's highly variable practices in the cardiothoracic ICUs, and we also identified that the commonly used 3-ounce water swallow test misclassified aspiration status in 1/3 of acute cardiac surgical patients. So overall, these data highlighted the need for improved swallow screening procedures and practice guidelines to enable early detection of dysphagia and ultimately mitigate the development of adverse patient outcomes. So in phase 1, we showed that currently clinicians did not have guidelines to inform them of how to identify or triage high-risk patients to specialized services, which was impacting practice patterns. However, the development of these specialized care pathways were really hindered by the fact that the prevalence of swallowing safety impairment and relative risk factors in complex cardiothoracic surgical patients was largely unknown. For those curious why it was unknown, it was because the majority of literature out there was using subjective versus objective assessments to quantify dysphagia status. So this is things like clinical swallowing evaluations, or positive screening results, or maybe ICD-9 codes, instead of using instrumental assessments to quantify dysphagia. So therefore, we aim to determine the prevalence of dysphagia. We also sought to identify relevant demographic and or surgical risk factors, which may be predictive of dysphagia status. I'll now present the key results, namely regarding rates and risk. So, a total of 182 adult patients undergoing cardiac surgery with no history of dysphagia underwent a standardized postoperative FEES within 72 hours of extubation. Imaging confirmed that unsafe swallowing was observed in 94% of patients and aspiration in 29% of patients. Notably, silent aspiration or aspiration without a behavioral cough response or a throat clear was observed in 53% of aspirators. Looking at the 1 in 4 cardiac surgical patients with postoperative aspiration, risk factors included reoperative procedures, endotracheal tube sizes of 8 or greater, New York Health Association scores of 3 or greater, intubation of more than 27 hours, and transesophageal echocardiogram procedures with more than 110 images. Importantly, aspiration was associated with increased time to oral intake, pneumonia, reintubation, longer ICU and hospital stays, increased cost of care, and death. And you can see here, if you had 3 or more of these risk factors, it's 16 times higher odds, or 4 or more, it's an estimated 22 times higher odds of aspiration confirmed on instrumental assessment. We also utilize a single site retrospective review of consecutive lung transplant patients at UF Health over the course of 3 years. So these are among our most complex and critically ill patients. We reviewed video fluoroscopic swallow exams pre-transplant and post-transplantation and found that the rates of unsafe swallowing increased from 17 to 84%. Interestingly, rates of postoperative aspiration increased from 7 to 45%, with silent aspiration present in nearly half of post-transplant aspirators. So this was pretty significant. We had initially expected going in that pre-transplantation, there would be a higher amount of people with preoperative and pre-transplant dysphagia, given the fact that so many of these people were living with end-stage lung disease. And we were pretty startled to find that the prevalence was actually much higher postoperatively. So this is very indicative of a true incidence of postoperative dysphagia after transplantation, after lung transplantation specifically. Looking at the 1 and 2 lung transplant recipients with postoperative aspiration, venous-venous extracorporeal membrane oxygenation, reintubation, tracheostomy, and intubation duration were identified as risk factors for postoperative aspiration. Specifically, VV ECMO and reintubation were independent predictors of postoperative aspiration. Compared to non-aspirators, patients on VV ECMO at any time point were observed to have 6.7 higher odds of developing postoperative aspiration. And lung transplant recipients who underwent postoperative reintubation had 4.5 higher odds of developing postoperative aspiration. And I just wanted to take a moment to clarify that when I say reintubation for lung transplant population and lung transplant recipients, I do want to clarify that this is technically 3 intubation events. The first being the first intubation with a double lumen tube, then the transfer to a single lumen tube, which occurs in the operating room and in the OR. Then after they are transferred into the ICU, if there was another intubation event or reintubation after the OR, then that would count as the third. So they're typically being performed 2 at baseline and then 1 in the ICU. Here are conclusions regarding rates and risks. Dysphagia is common in cardiothoracic surgery patients. The majority of cardiac surgery patients present with unsafe swallowing. Pre-existing dysphagia was low, however, increased 5-fold after lung transplantation. And predictors of postoperative aspiration include factors related to endotracheal intubation, such as duration and size. So this is not new for us. All of us are very familiar with the fact that ETT size and duration impact the risk for postoperative dysphagia. This is something that's well established in the literature. And increased respiratory dependence, such as reintubation, tracheostomy, may also increase risk, and also markers of disease severity, such as prolonged dependence on VV ECMO, New York Heart Association scores, etc. And I think that the markers of disease severity, really speak to sort of increased awareness of factors related to frailty, aging, the deconditioned status of many of these critically ill or medically complex patients at baseline, and how this constellation of these symptoms or syndromes may predispose a person to having an increased risk for aspiration. So in phase 2, we showed that there are high rates of cases of dysphagia and the risk factors for impaired airway protection in both cardiac and lung transplantation patients. However, mechanisms of impaired airway protection and defense during swallowing in these patient populations still remain somewhat poorly understood. Therefore, in phase 3 of this initiative, what we sought to do was test the hypotheses that unsafe swallowing is related to impaired breathing, disordered cough, and atypical respiratory swallow coordination. And it is important to appreciate that much of this work is still underway, and these findings are very preliminary in nature, as the work in cardiac surgical patients is still being conducted now over at Ohio State and UF collaboratively with Dr. Plowman. Here I'm going to focus mostly on the most complex cardiothoracic surgery patients that I've had the privilege to work with, or lung transplant recipients. So a single site prospective cohort study recruited patients status post bilateral lung transplantation from August 2020 to August 2021. Respiratory telemetry metrics, namely respiratory rate, was collected before and after the administration of a 3-ounce water screening task. Flexible endoscopy was used at ICU bedside to identify people with and without aspiration. And we found that baseline respiratory rate and magnitude of change in respiratory rate after swallowing was significantly higher in aspirators versus non-aspirators. And further, silent aspirators demonstrated higher baseline respiratory rate compared to non-silent aspirators. In the same investigation, voluntary cough airflow testing was performed. An analog peak flow meter was used to record peak expiratory flow rate, and these data were compared between swallowing safety and aspiration response groups, objectively confirmed by FEES imaging, and no significant differences for voluntary cough peak expiratory flow rates were found between aspirators and non-aspirators at about 213 versus 277 liters per minute. However, within the aspirating lung transplant group, voluntary cough peak expiratory flow rate was significantly reduced, and on average, half the value in silent aspirators compared to non-silent aspirators. 166 liters per minute versus 324 liters per minute. And I think it's important to recognize as well that when you look at these numbers, a significant amount of these data points are actually well below the 200 line, or simply going below 160 liters per minute, which we know is actually a critical threshold for being predisposed to not having effective airway clearance, or the forced shearing capacity to effectively clear aspirate material or silent aspirate material if it exists or occurs. In a preliminary pilot investigation, we performed respiratory swallow coordination testing at ICU bedside. We used respiratory inductance plethysmography, nasal airflow cannula, and flexible endoscopy, Overall, we found atypical respiratory swallow coordination in lung transplant recipients with significant differences between healthy normative reference data and swallows from lung transplant recipients. So to the left here, you see respiratory phase patterns. Here we see in lung transplant recipients an optimal expiratory pattern occurred in only 18% of swallows, which is a stark difference compared to the typical proportion of respiratory swallow phase patterns for liquid swallows found in healthy adults, where upwards of 93% have an expiratory swallow expiratory phase pattern. We also found that atypical respiratory swallow coordination was associated with unsafe swallowing. And compared to safe swallows, unsafe swallows demonstrated longer respiratory pause duration, about 3 seconds versus 2 seconds, and also were initiated at 3 times higher estimated lung volumes at swallow initiation at about 12% vital capacity versus 4% vital capacity. So in conclusion, dysphagia, dystussia, impaired cough, and elevated respiratory rate coexist during eating and drinking in lung transplant recipients. Atypical respiratory swallow coordination may increase risk for dysphagia-mediated complex cardiothoracic surgery patients with end-stage lung disease. And future work really is needed to validate these preliminary findings. So here are some central messages that I hope you're able to leave with today. The first is that there's high variability in swallow screening protocols due to lack of formal practice guidelines, and sometimes the assessment tools that we're using in hospital settings or acute care settings may not be sensitive or specific enough for a homogeneous population. So we need to have a little bit more concern about the validated or not validated assessment tools that we're using. And also that swallow safety impairment or dysphagia with airway invasion of food and liquid aspiration is definitely very prevalent in complex cardiothoracic surgery patients, I think more than any of us had anticipated. And lastly, that preliminary evidence suggests that atypical breathing, cough, and respiratory swallow physiology may actually increase risk for dysphagia-mediated aspiration in these patient populations. So some evidence-guided recommendations. So what do we do with this information? How can we translate it clinically? And how can we apply this knowledge gained? Well, the first thing I think it's very valuable to remember that SLPs are critical members of the cardiothoracic ICU team. So one way to maybe approach this or kind of combat some of the findings that we discovered is providing swallow screening in services and having interdisciplinary discussions to maybe improve practice patterns for frontline providers. So this could be something like having conversations with your nurses about what their screening protocols are, maybe making sure that there's a solitary screening protocol that is currently in place in certain ICUs rather than others, and really working collaboratively with physicians to bring attention to this population. I actually, continue to present this data mostly because I increasingly find that even though, it has been out for a few years now, there are still hospitals who are not maybe recognizing or appreciating the amount of the high prevalence of dysphagia that actually occurs in cardiac patients, cardiac surgery patients, and in lung transplant patients. So you really can have a role of advocacy in screening and identifying those patients early. Another is the high rates of subclinical dysphagia or silent aspiration supports the need for direct imaging. So because not only dysphagia and dystussia or cough dysfunction exist in these groups, it also exists in a very covert or silent way, and many of them may be missed because of silent aspiration when they're being evaluated at bedside or evaluated with screens. So using direct imaging like flexible endoscopy or modified barium swallow studies is actually more relevant and salient for this patient population than perhaps was historically thought of, or maybe previous dogma would suggest. So individuals also with accumulated risk factors should be considered very high risk and high priority for referrals. So I know that when I'm working clinically and when I've worked clinically in the past, not everybody has, a ton of slots, right, for fees or for fluoro during the day. It may be that you're at a center that only has, 3 or 4 slots a day, maybe even as little as one. Maybe you're at a center that's very fortunate where you have it accessible to you all the time. But if you're currently at a location that maybe doesn't have the direct access to constant fluoro or fees if you need it, a way to potentially handle this situation is to triage your patients based on the risk um, and looking at their whole clinical profile and building somewhat of a risk stratification tool yourself, although it is not an evidence-based risk stratification tool that was kind of conglomerated together through a clinical trial. Still, we could use these tools in a template or in the form of our clinical swallow exam to see who should sort of rise to have higher odds at the top of your list when you're triaging patients to get a priority fees or fluoro. And also that clinically distinguishable responses in respiratory rate, voluntary peak cough flow, and breathing patterns may be integrated into objective and subjective metrics of SLP evaluations. So what I mean by this is that when we're conducting a clinical swallow evaluation, we may be able to use both objective and subjective measures that we are obtaining to integrate into our CSE, like looking at respiratory rate, perhaps collecting voluntary peak cough flow. If you are at an acute care center, actually a lot of respiratory therapists may have an easily accessible peak cough flow meter available in the stock room or something that they use that can serve as an adequate substitute. If you have a patient who's in an acute care setting for a long time, is extremely deconditioned, say you're at a level 1 trauma center where you have patients who are in an ICU for upwards of a month or 2 months, perhaps their family members would be open to getting a peak cough flow meter or an EMST device to use at bedside if your facility can't directly acquire it for them. And also looking at breathing patterns. So, the same way that we are able to evaluate breathing patterns, looking through spirometry, which is the more formal way, we can also, visualize, looking at chest wall movement and discussing more the expiratory pattern, and potentially just paying more attention to how our patients are breathing while they are consuming a meal or perhaps during your clinical swallow evaluation, and even if it's integrated into your potential CSEs or in your fees and fluoro exams. So a big thank you again to my mentors, co-authors, collaborators for involvement in this work. It's truly a team effort. Interdisciplinary science is a huge team effort and requires a ton of collaborators and people who are heavily involved. So I would like to thank all of these people for that. And also my current lab members at Upper Airway Dysfunction Lab and my current mentor as well for helping us get some of this research out and disseminating some of this work. Here are the references. And now I'm willing to take any questions that you may have. And also my email is right here on the bottom as well. So if you have any questions about any of the studies or the study design, or if you just want to chat, I would absolutely love that. Feel free to reach out to me.
Thank you, Justine. That was really informative, and we appreciate you being here and sharing your email. If anybody has any questions, I know there were some questions in regard to research papers. I'm sure we can email if you don't mind sharing your references for that. And a couple questions. We'll open the floor so you can either put your questions in the chat or the Q&A. What we have right now is, do you have research? Are you involved in any research on patients with dysphagia who also have suffered an anoxic brain injury?
That's a nice question. Thank you. Actually, I am not involved in any research for patients with anoxic brain injury, but I do think that's a really interesting area of research, and I can imagine that they probably have relatively diffuse swallow and cough deficits.
So I know lung transplants and cardiac, and are there any other populations that you are involved in your research?
Yeah, so currently, some future directions that we're looking at in the upper airway dysfunction lab is actually we're looking at patients with head and neck cancer, looking at specifically cough dysfunction in individuals with head and neck cancer, and looking at potential treatment pathways for that. So if you have any local in New York or even non-local who are willing to fly in for some of our research studies, please let me know, especially with patients with late radiation associated dysphagia or chronic dysphagia. We also have some clinical trials ongoing under Dr. Michelle Trochet for cough skill training in Parkinson's disease. And there's also an expiratory muscle strength training component to those studies as well.
And can you talk a little bit more about how you've used EMST or any respiratory muscle training with these populations and what kind of results you have seen?
Sure. Yeah, so for the cardiac surgical patients, EMST has not been formally studied in the postoperative group, but actually Dr. Kara Donahue recently looked at EMST in preoperative cardiac surgery patients with some pretty nice results. And this is to really increase the physiologic reserves that these patients have. So hopefully when they come out of surgery, they're working from a higher threshold and have some better outcomes with breathing, swallow, or cough. We know that cardiopulmonary rehabilitation and building expiratory strength training can also have some transfer effects to these different functions. For lung transplantation patients, I actually would love to work on an expiratory muscle strength training clinical trial because I think it's highly relevant for this group. There are a few institutions like at Duke University and at Columbia University Medical Center who have already started using expiratory muscle strength training post-operatively to, kind of help patients with both their cough and expiratory function. And they have been reporting anecdotally that they're having good results. If you do want to, pursue that pathway with one of your lung transplantation patients, for example, I think it would be a very valuable thing to first consult with your physician, make sure there's no potential contraindications, that it's not too early in the process. And as long as you receive, sort of medical clearance for your patient to pursue these expiratory muscle strength training, it could be extremely valuable and helpful for building up their breathing reserves.
And I think that's the case in a lot of medically complex patients. People write in often and are like, can I do it with this patient? And, there's no blanket yes or no answer. It's always very, very individual. And it's always something when you consult with your physician and your team that they can kind of give you a better idea of if what the patient is able to tolerate and what is safe for them or not. But definitely very valuable if they are able to. Okay, let's see. Do you think that any of this would translate to the pediatric population, the cardiopulmonary population? I don't think we have any research there yet.
Yeah, so Dr. Emily Plowman is actually starting to work on a whole subset of research studies looking at cardiac patients who are in the pediatric ICUs, I believe, and I think some neonatal patients as well. So stay tuned for that literature coming out. But I certainly think that there could be a lot of translation. I really do feel like it is a shame and a disservice to the children that we do not have as much pediatric research as we do adult research. And I think that, and keep in mind, this is somebody who has not worked in pediatrics for a very long time, but I would infer that we're probably not giving kids as much credit as they probably deserve, and that they're probably really able to participate in these treatments.
Yeah. And I'll say clinically, a lot of, children's hospitals will use respiratory muscle training very carefully because obviously we have to evaluate the data and the data is limited, and then think about the translation and the safety of it. But when they are able to use it, generally they do have good results. So if it is safe and it's something, then it might be something to consider. Let's see. And is there a good resource for norms to compare peak flow meter measurements to? Do you have a paper specifically?
Yeah, so this is a great question that we always get asked. Um, Unfortunately, there is no like perfect resource that has all of the norms for peak expiratory flow rate or for cough normative values. But what I will say is that what I would typically recommend is looking at what is observed in each clinical population, which there are many, different papers that are producing data on the type of peak expiratory flow rates that you could expect for a certain disease process, whether it, for example, is Parkinson's disease or whether it is ALS or whether it's, lung transplantation, and sort of using that as a bit of a barometer to see how your patient falls. Are they above what's typical for their disease process? Are they below? And if it's a healthy person, then I think looking at just generalized pulmonary function is probably a really valuable surrogate, because what we do know is that when you're looking at breathing metrics, it depends on a wide variety of things. We're talking about our body mass index, the size of our thoracic chamber. Obviously, there's extreme variability in what could be considered a healthy cough. But I'm happy to share a few papers with you that may be helpful or discuss specific population-based data.
Thank you. And we have this question from Stephanie. Do you have any recommendations on resources, current studies for treatment of cough? I'm often having trouble finding resources for treatment for all populations.
Yeah, so let me just go back to this slide. Oops. So right on this slide, if you scan this QR code, this will take you to a comprehensive review of treatments for cough. And it actually goes through all the different populations. It discusses all of the available literature, and it provides a few case studies. It also provides a framework for considering cough treatments, both exercise-based and compensatory-based and skill-based trainings. And in it as well, we provide a few nice tables. So hopefully this will be kind of the comprehensive guideline that you're maybe looking for. We really created this as a tool for that exact question.
Perfect. Can you talk about some of the interventions aside from EMST or RMST that have been helpful or you have found to be helpful?
Yeah, of course. So one of the key interventions that I think is very helpful and up and coming and can be applied more is cough skill training. And so this is repeatedly coughing into a analog peak flow meter. It could be handheld. It does not have to be spirometry based to improve, the coordination and potentially the strength of cough. There was a clinical trial that was conducted by Dr. Michelle Trocchi's group from the Michael J. Fox Foundation that shows the relevance of cough skill training. So I think that this is one of the kind of top tier treatments that we could potentially be using. Another thing that I think is really important to think about, especially when we're thinking about critically ill populations, is really the collaboration with our respiratory colleagues. We know that also EMST has its own role in improving expiratory flow pressures and also RMST and inspiratory volume as well. But going beyond that, I think there's a really valuable role in collaborating with our respiratory therapists and looking at things like airway clearance, proximal airway clearance techniques, even some, potential diaphragmatic techniques. For example, if you have a patient with ALS or amyotrophic lateral sclerosis or end stage respiratory failure due to a neurodegenerative process, it may be time to consider these more compensatory techniques that we certainly have a role in helping to execute, to help with forced shearing capacity, to help evacuate excess secretions, to manage secretion burden, and to improve airway patency overall. So I think sometimes, we do have to have a more holistic and well-rounded approach to figuring out what our patient specifically needs, whether that's rehabilitative or compensatory, and also starting to think about what's in our scope of practice where we actually can be more collaborative with our colleagues to help execute those things.
Yeah, I fully agree. I'm a strong believer in interdisciplinary care, and I think this is a great opportunity to do that, to learn from each other and work together, combine our powers for
I
the
agree.
better. Okay, and we have a question from Madeline. Some of the research you presented showed some results between aspiration and penetration. How was penetration defined? Was there any differentiation between flash, shallow versus deep penetration? Was the penetrated material cleared?
So this is a great question. So we did use categorical groupings for these studies where a penetration aspiration scale score of 3, 4, and 5 qualified as penetrations, and 6, 7, and 8 qualified as aspiration events. I hope that helps clarify.
Okay, and then to follow up on that, with the 3-ounce water test being less sensitive in detecting aspiration in the cardiothoracic population, was there any correlation with dysphonia? Is the research suggesting we should complete instrumentation on all cardiothoracic patients?
Ooh, I mean, in a perfect world, if you have the resources to do so, and you think that your patient is relatively, I mean, I wouldn't suggest it for low risk because I think that that is kind of a misuse of resources. I do think we need to have the right, kind of clinical constellation, in order to indicate the exams. I don't think we want to, increase patient burden by conducting unnecessary exams. But I will say, that I think, generally speaking, if you have, a pretty complex cardiothoracic surgery patient, that it is indicated. And we do actually know that about, and this is another study that came out of with the Plowman group, that about 1 in 4 cardiac surgery patients will have some form of vocal full motion impairment. So, this can kind of be co-occurring with dysphagia or not. So I think you kind of have a double benefit of conducting an endoscopy.
Yeah, great. A lot to think about there. And okay, we have another question from Martha. It says, does the SLP require to be trained on EMST to implement the treatment? And I'll just say that there is no certification required to conduct respiratory muscle strength training, but we highly recommend taking a comprehensive course. These courses outline the anatomy, physiology, and teach the clinical application of the intervention so that you have a good idea about how to adapt the intervention to the individual. And
Yeah.
Julie asks, it sounded like you did your instrumental tests within 72 hours of extubation of CTS patients. Have you found a specific time frame or indicators where incidence of aspiration is reduced?
That's a really good question. I love that question. So I do think, it's a little bit of a double-edged sword. If we're talking about our relatively healthy cardiothoracic, patient who came in at baseline, I do think that there's probably, right? And this hasn't been studied longitudinally, so I'm just saying this based on speculation. I do think that there's probably, more of a direct relationship between time and the amount of spontaneous recovery that you're going to get if we're not talking about a significantly deconditioned patient. With that said, I do think, that part of the reason why we were using the bandwidth of within 72 hours is because, and I'm sure many of you could speak to this, I think a lot of hospitals and acute care centers may have some unnecessary protocols in place where they say, it has to be a certain amount of hours before we're going to conduct an endoscopy, or there needs to be a certain amount of time. And unfortunately, what happens, with the third of patients who are misclassified, on the other end of that totem pole is that there are patients who are being who are being held NPO for no reason. So you want to kind of get it if your patient is appropriate and can tolerate it, and you have an order from your physician or from your surgeon to conduct, a swallow exam. I think that there's a huge benefit of getting in earlier and returning to an oral diet if patients can.
Yeah. Anything we can do to help the patients eat faster, right?
Yeah,
And a few people have asked about the the scan codes. So Dr. Dallal-York has shared her email. If you don't mind going back to that screen, and I will share mine. My email is Jenny, Jenny, at emst150.com. You can also email me if you need a certificate of attendance or if you would like any of the QR codes. I can help you access those also. And I will put my email in the chat for everyone.
just scrolling through here. Sorry, look at that last page.
I know
But yeah.
I made you go all the way back.
Yeah, no, I'm sorry. Almost there. But yeah, I'm happy to send over those resources directly. But even when you watch the video recording, if you would like to go ahead and scan the QR codes, they should open directly to those links. And those are both open access resources, so you shouldn't have any kind of barrier to obtaining them.
Yes. And I can link you to because I have those papers as well.
Oh, great.
We did test the QR codes though. You have to get it at a certain angle, but they do work. Uh, Stephanie, the chat is disabled, but so Jenny at emst150.com if you need to email me. And we'll take one more question. This one is from Yana. Have you ever worked with patients post-tracheostomy? If so, is there a specifically tailored treatment to improve swallow, cough, and phonation function?
Wow, this is a really great question. I have worked with patients on post-tracheostomy, and I really think it is highly dependent on the underlying pathophysiology and why they have their tracheostomy in place. For example, if you have a patient who has a complete airway obstruction due to an head and neck cancer tumor, that is going to call for a different sort of treatment paradigm than somebody who has a tracheostomy for something like ALS or somebody who has an emergent tracheostomy for something that's acute and is going to resolve rather quickly. Unfortunately, I think because of the complexity of the underlying rationale for why people have tracheostomies, there isn't sort of a one size fits all protocol. But I would recommend looking at Stevie Martin's work at University of Wisconsin. She has a lot of nice literature on tracheostomy and may have some information about certain treatment paradigms for certain populations.
Yeah, and I'll say I have worked with a lot of tracheostomy patients in my clinical work at an LTAC, and I have been successful in using RMST with them, but it does have to definitely be tailored. And this is why even though you don't need a certification to do the RMST, it's great to have a comprehensive understanding of the intervention and have a team that is also working with you. If anybody wants more of those resources, you can also email me. I have put together research lists for a lot of populations. So tracheostomy and critical care is one of the ones that is close to my heart, though. Okay. And with that, we are going to finish up. Thank you so much for speaking with us this evening, and I hope everybody has a good night. We are doing another webinar in February on the 19th, and that will be presented by Lauren Meffin, and it will be on head and neck lymphedema, a nice overview of that for everyone. So we hope to see everybody there. Have a good
Thank
evening.
you.
Thanks. Bye.